Before we get started, just a quick word from World Extreme Medicine. If you work in pre-hospital, remote, expedition, humanitarian or high-risk environments, World Extreme Medicine exists for one reason: to help you deliver safe, effective care where resources are limited, decisions matter, and help is a long way off. From expedition and wilderness medicine to hostile environments, dive medicine, leadership, and human performance under pressure, World Extreme Medicine bring together clinicians and operators with real-world experience in some of the most challenging settings on the planet. Their courses, webinars, and global faculty are built around practical decision-making, not just theory, to focus really on what actually works when things go wrong, far from definitive care. To find out more and explore upcoming courses and indeed educational content, visit worldextrememedicine.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. I'm joined here again by Sarah Spelsberg, who is a doctor, a friend and colleague, and indeed a co-host on the World Extreme Medicine podcast. Sarah, welcome to the podcast.
Thank you for having me. I appreciate it. I'm glad to be here.
So we're going to unpack today The Circle of Life. It's a fantastic blog post that Sarah wrote. You'll see it in the show notes. And it really is around the contradiction in terms, but also the necessary reality that in one shift you can both treat someone with a terminal illness and indeed deliver a baby in the same shift, and sort of see both ends of life in that shift. Sarah, could I get you to sort of speak to and just maybe contextualize the blog for us?
Absolutely. I wrote this because I was so moved by the experience, and I was having difficulty kind of even wrapping my head around it, because there was just such profound grief and then such profound joy all in the same short time frame. And so at the time I was working out on a remote Aleutian island off the coast of Alaska in the Bering Sea. And one of the island residents who had been a longtime resident, born and raised on the island, and he had a terminal illness and he wanted to die on the island. I mean, I am emergency medicine trained. I'm not hospice trained. But I do have end of life discussions with families, and I have, goals of care discussions with families. And so, when he said he wanted to stay, I who am I to stop him? He needs pain medicine because there's an aggressive cancer at play, and that can be quite painful. So he needs more pain medicine than I would ever give anybody. But we were all comfortable doing that in that particular situation because it's, you're honoring a man's dying wish. And the day he died, he was at his home, and his family let us know that he had passed. And I went with the paramedics because he was, a full-grown adult. And so it's going to take a lot of us to get him, into a body bag in a dignified way and get him out of the house and into, the ambulance and back to the cold storage for preparation for his burial plans. And so I went with my team because I both wanted to be there to support them, because I've been EMS before in my previous career, and it just means a lot to me to have a close relationship with the EMS that I work with. And so I went with them, and we kind of got ourselves into the house, and we got back there and said some kind words about him, and told him we were sorry that this was how everything ended for him, and then very carefully and methodically got him into a body bag and got him out of the house. And it just, the family was very sad. He was kind of an anchor of the family. And it was just a really, really profound experience to try to be there in an official capacity and on the margins of this family's grief. And I was honored. I was honored that everybody was on board. I was honored that we allowed him to leave the world on his own terms, the way he wanted to. And so he got to stay on the island until the end. And then I hadn't delivered a baby, in 10 years, because it's just not something that happened to me very often. And he, so I get a call from dispatch, and he says, "There's someone on the way to the clinic in labor." And I was like, "What?" really? Like, is this a prank? And he said, do you want me to call anybody? And I said, I want you to call everybody. Like, if they've had a baby, if they know a baby, if they know someone who's pregnant, if they've ever been pregnant, like, please come, like, help. I have not done this in 10 years. It just hasn't happened. And so and then I wonder, how much time do I have? And he said, well, they're on their way now. And I lived above the little ER in an apartment, and I run to the window and I see this truck just screaming into the parking lot. It's 11 o'clock at night. I'm in my pajamas, which is like a t-shirt and shorts. I jump into my flip-flops. I go running down the stairs. I run up to the car and I say, just give me a second. I'll get a wheelchair and we'll get you inside because it's raining and it's cold. And the mother says, I don't know if there's enough time. And so then you take a look and there's a head, and here he's coming, and he's got the cord wrapped around his neck. He's like as blue as my glasses. I'm holding him up by his ankles, trying to get the cord unwrapped because I'm by myself. Dad's, trying to put the car into park, and mom's in the front seat. And I don't know what to do. And so I just smacked the baby on the behind because mom's going, why is he blue? And I'm like, because he's not breathing. This is the worst day of my life, like officially worst day of my life. And like, oh God, if we lose a baby. And so I holding him up by his ankles and I just smack him as hard as I can with on his buttocks. And he starts crying. And when he starts crying, he turns pink. And baby's okay. And so, I've got the baby. And then I'm like, well, now what? Like, we haven't delivered the placenta yet. It's freezing out here. It's raining. He's still attached by his umbilical cord. I'm by myself. I can't like, it was one of those moments where I'm like, I'm sure I would have pulled myself together in a second, and I would have been like, all right, mom, you hold baby, I'll go get a wheelchair, we're gonna be fine. But then one of my beloved paramedics runs up and he just said, orders, please. And I said, I would like a blanket and the thingies that we clip and some scissors, sterile scissors to cut this, to get baby separated because now it's been at least 2 minutes and baby's gotten enough from mom. It's time to cut the cord. And I asked, and the paramedic goes running inside and came back with everything. And I asked Dad if he wanted to cut the cord. He didn't, so I cut the cord. Actually, maybe the paramedic cut the cord. I might have put the clamps on and held it, and the paramedic cut it. And then I wrapped the baby in the blanket, and I told the paramedic, "You're on mom duty." And he helped mom into the ambulance, and we got the baby inside, got it warm, and then once like we felt like we did our APGARs, and then like I know there's three things that babies need, and so I'm like, I know they need something in their eyes, like the erythromycin ointment in their eyes. They need Hep B and vitamin K. Like I've never given this stuff in my life, and so but we have it, so okay, let's do it. And then we called Anchorage and talked to an OB up there to make sure we were doing everything okay. And then put the baby on the mom's chest like you would normally would. And then I just kind of sat down and I was just like, what a weird time. Like we just helped this man, pass, spend the last few weeks of his life right where he wanted to be, and put a man in a body bag and took him to the morgue. And then we delivered a baby. And it's such an odd thing that happens. We're born and we're completely clueless, and we grow up and we try to figure out our purpose in the world, and hopefully we help and don't cause too much harm to others. And then, hopefully after a long life, we pass. And it was just I mean, it's not a new thought. It's not a profound thought. It's something that I think anyone who's self-aware thinks about, probably not infrequently. So it's not like I'm the first person to have this existential crisis, but it just was it hit me really hard, and I was like, I feel like I need to I need to put this down on paper.
Yeah, listen, I'm glad you did. It's a fantastic read. And to your point around just the versatility and flexibility that you need as a practitioner to navigate the same 12-hour shift. So, like you said, just, the indigenous respect and also just bringing someone's life to a close and honoring that, and then the frenetic activity around the start of a baby's life, all in the same shift. And it's happened to me before in very different contexts, but just you finish a shift and you think, gosh, it's a real privilege to be at both ends of life and to see both ends of life in such a visceral way.
And it makes you value the middle of it. I value every day. Like I wake up and I think, wow, how cool is this? This is amazing. I get to do a job I like. I've worked really hard to get where I am in my career. I'm enjoying every second of it. I get snippets where I get to help people and really make a difference. Sometimes I'm just medium and I'm just sort of along their road of whatever they're going through. But sometimes we actually get to really make a difference. And what a privilege it is to be at the beginning, in the middle, and at the end. It's incredible.
Yeah, it is. Absolutely. Absolutely. So you're just about to hear the blog in AI format. You can read it in the show notes. Sarah, it's always a pleasure. Thank you so much.
Thank you, Owen. Thank you for having me. And everyone, please join us at one of the WEM conferences.
Okay, so let's get into this. We are diving into a source today that it really redefines the boundaries of emergency medicine.
It really does.
And this isn't some fictional story. This is a personal reflection from Dr. Sarah Spelsberg, and it chronicles two of the most profound human experiences possible.
Life and death.
Exactly. Life and death handled by the same small team in a really remote setting, all within just a matter of days.
Yeah, and that's our mission for this deep dive.
Yeah.
We're looking at what happens when highly trained experts, people skilled in wilderness and emergency medicine,
Right.
are confronted by scenarios that just push them so far beyond their usual comfort zone. We're going to try to synthesize the clinical standards, the logistical hurdles, and I think most importantly, the mindset you need when every single second counts.
And every single supply, I imagine.
Oh, absolutely.
The account, it's just a perfect narrative arc. It traces the emotional whiplash of this team. They first manage a peaceful, anticipated death, and then they're thrown into a terrifying, chaotic emergency birth. It's a real study in professional adaptability.
It is, and the whole thing is summed up by this one quote from the doctor herself.
We are born, we live, we die. Make the most of your short opportunity on this earth.
It sounds philosophical, and it is, but it's also, it's a clinical reality check. If you sign up for remote care, whether that's on an island or in some mountain town, you have to be ready to manage the entire spectrum.
The entire spectrum of human experience, sometimes at the same time and always with, nothing.
Always with minimal resources, yeah.
Which brings us to that incredible swing in emotional extremes that the team faced. The source material starts with what sounds like just really respectful, holistic care. They're attending to a terminally ill patient, assisting with an anticipated death. The patient specifically wanted to pass away in a quiet, remote place.
Yeah, without all the noise and intrusion of a big tertiary hospital.
Right. And that planned event, it's clinical, but it's also so personal.
It's palliative care at its highest level. I mean, the objective is crystal clear. Comfort, pain management, dignity.
The environment is controlled.
Completely. Needs are anticipated. And the event, while sad, was described as beautiful and ultimately peaceful. The team was operating, exactly where they were supposed to be.
Within their well-rehearsed scope of practice.
Exactly.
So they successfully navigate this final passage of life. They're probably feeling that quiet satisfaction that comes with honoring a patient's wishes, but the universe wasn't quite done with them.
Not even close. Days later, they're jolted from this state of dignified calm by the complete opposite.
The sudden, chaotic arrival of life.
The contrast just couldn't be starker. They're awakened for an imminent birth. And it's not happening in a sterile clinic.
Yeah.
It's happening outside in a very remote location in inclement weather. It just shifts everything from quiet anticipation to pure primal emergency.
And that logistical shock, that's what makes the account so gripping. Dr. Spelsberg really emphasizes the chaos. She says she had no supplies initially.
Not even the basics.
No PPE, no gloves, no mask, because she literally ran out in pajamas.
That detail about the pajamas is just, it's so critical. It shows you that in true remote emergencies, preparation means training your muscle memory.
Right, because you won't have time to grab your gear.
You won't even have time to put on shoes. The core lesson here, which she highlights, is that you can plan for death, but life schedules itself. The baby was coming whether we were ready or not.
And they weren't ready. Running out in your pajamas to deliver a baby in the cold, I mean, that image sticks with you.
It does.
And what saved the situation wasn't just individual bravery, it was immediate, effective teamwork.
Absolutely. The immediate need was to just mobilize everyone available, regardless of their specialization. The doctor talks about her gratitude for the arriving team.
The cavalry.
The cavalry, yeah?
Yeah.
The paramedics, the registered nurses. And she says something so important. Never underestimate what a mother, paramedic, or RN might know more than you.
In a crisis, you leverage every single piece of knowledge on site.
Every piece. A paramedic's training and stabilization, an RN's broad clinical experience, that all becomes just as vital as the doctor's specific trauma expertise.
That team dynamic really sets the stage for the next part, which is the clinical hurdle of the delivery itself.
Right.
This team, they're veterans of extreme medicine, wilderness, trauma, heart attacks, appendicitis. They're used to it, but obstetrics, they were rusty.
Very rusty. They admitted they hadn't delivered a baby since 2005.
Wow.
And that gap, it instantly elevates the risk from challenging to terrifying, as the doctor said. They were operating way, way out of the comfort zone.
And that feeling is important. Even experts feel fear when they're faced with something rare and high stakes.
Of course. And the risks here were not theoretical at all. The source lists several factors that made this a really dangerous situation.
So for you, the listener, what were those critical factors that really cranked up the danger level?
Well, what's sobering is how quickly the worst-case scenarios start to build.
Yeah.
First, the baby was described as large.
Okay.
Second, the mother had little to no prenatal care. So they had no baseline, no confirmed due date, nothing.
They're flying blind.
Completely. And third, she had known gestational diabetes. You put those three things together, and you have a dramatically increased risk of 2 potentially catastrophic complications.
And those complications are, let's be clear on the stakes here.
Okay, so the 2 main clinical nightmares in this scenario are shoulder dystocia.
Which is when the baby's shoulder gets stuck.
It gets literally stuck behind the mother's pelvic bone after the head is delivered. It leads to immediate fetal distress. The other is postpartum hemorrhage.
Massive bleeding.
Massive, life-threatening bleeding that can happen minutes after delivery. In a remote setting, that is often a fatal complication because you can't just replace the blood that's lost.
It just paints a picture of intense pressure. And the doctor even mentions her own limitation, having small hands, which in a complicated delivery is a genuinely relevant factor.
It's the reality of working with what you have. When you're at the edge of the map, you realize you can't just rely on special instruments or, backup from down the hall.
So their immediate response had to be using their best non-physical resources.
Knowledge and consultation. That's it.
And that's the crucial safety net they set up immediately. They called an OB specialist for real-time guidance. And they reviewed the standard of care for post-delivery. It just reinforces that old saying, colleagues are the best, never burn a bridge, phone a friend.
That professional network is the most advanced piece of equipment they had. The ability to pull up protocols while having a specialist on the phone guiding you. That's what turned a potential disaster into a success.
Which brings us to their next steps. The critical protocols for stabilizing everyone.
Right. So let's talk about what they actually did.
Okay, let's dive into those protocols. As you said, the biggest threat was hemorrhage. How did they use pharmacology to prevent that, given their limited supplies?
This is where their clinical judgment under pressure really shows. They knew they couldn't risk a bleed they couldn't control. So immediately they went pharmacological. The mother was given 10 units of pitocin.
Intramuscularly, so I am.
Intramuscularly, yes. Now, for anyone who's not medical, pitocin is the standard drug used right after birth to make the uterus contract. Forcefully.
And a contracted uterus clamps down on the blood vessels that were feeding the placenta. It dramatically reduces bleeding. It's the first line of defense.
So that's the primary proactive move.
Yeah.
But they had a backup plan. They were thinking ahead.
Exactly. They were prepared to give 1 gram of tranexamic acid, or TXA, intravenously. 4.
And TSA is 4.
TXA is a powerful drug that helps stabilize clots and stop a hemorrhage when other things fail. Having both pitocin and TXA ready shows they were thinking 2-3 steps ahead.
And then just general support. Yeah, simple stuff. Cleaning her up, starting an IV line for hydration after all that stress and exertion. Stabilizing the mother first was key.
So once the mother was stabilized, they shifted their focus to the newborn. What was the critical checklist for the baby, especially with the mother's gestational diabetes?
So the newborn care is all about immediate threat assessment. The most critical step, because of the diabetes, was checking the baby's blood glucose right away.
To make sure it wasn't dangerously low.
Precisely. Then came the standard preventative measures. They gave erythromycin ointment to the eyes to prevent infections, which is, absolutely critical in a non-sterile outdoor environment.
Of course.
And they gave 1 milligram of vitamin K1, also an injection.
And the vitamin K is for clotting, because newborns don't have those factors yet.
That's right. It prevents something called hemorrhagic disease of the newborn, which could be just devastating in a remote setting. These are standard, immediate, non-negotiable steps for a safe delivery.
But here's where their judgment really shines, and where they actually deviated from a standard hospital protocol.
They chose to defer the hepatitis B vaccine. Why would they put off a routine procedure? That sounds like a risk.
It's not a risk. It's brilliant triage. This is the difference between optimal hospital care and necessary remote care.
Okay.
The Hep B vaccine is standard, but it's not immediately life-saving. In a hospital, the source notes, this vaccine is routinely given on discharge.
So it's not urgent.
It's not urgent in the first few minutes of life. In their high-stress, resource-scarce environment, they correctly prioritize the immediate life-sustaining procedures. By deferring the vaccine, they avoided adding any non-urgent complexity and just focused on getting mother and baby stable for transport.
That's a powerful takeaway for you listening, whatever your field is. Knowing the difference between what is urgent and what is routine is essential for crisis management. Sometimes the best decision is to safely delay a task.
It shows confidence. Confidence in knowing the standard so well that you know how to adapt it safely, rather than just trying to check every box in a freezing, suboptimal environment.
Their focus was 100% on stabilization and transport. It had to be.
Which brings us to the psychology of all this, because when the rest of the team arrived, they complimented the doctor on her calmness.
Right. She was clearly leading the scene with this intense outward composure.
Yes. But the doctor immediately corrected them, and this is the aha moment of the entire account for me. She explicitly stated she did not feel calm.
Not at all. She felt immense stress and terror.
And she gave them that fantastic line, "I told them not to confuse a little German stoicism with calm."
I love that line.
It just perfectly encapsulates the difference between your internal state and your external performance during a high-stakes event.
It's so crucial for understanding professional discipline. Stoicism, in this context, is a tactical choice to display an unshakable exterior.
It's a tool.
It is, because when a leader allows their internal panic to show, the team instantly loses confidence and efficiency. Her ability to execute complex protocols, delegate tasks, and maintain that link to the specialist, all while feeling terrified, that demonstrates a supreme level of professional conditioning.
So it's not about being calm, it's about acting calmly for the benefit of everyone else.
Exactly. It's a necessary performance. That outward composure, that tactical stoicism, it stabilizes the whole environment.
It lets the paramedics and RNs focus on their jobs?
Yes, setting up the IV, getting the drugs, monitoring the mother. They can focus on their tasks rather than managing the doctor's stress. It ensures the decision-making stays stable and aligned with that phone-a-friend standard of care instead of, devolving into panicked improvisation.
That psychological resilience is arguably the most valuable tool they had that night.
I think it was.
So this whole journey from that quiet, dignified farewell to the absolute chaos of a freezing, high-risk welcome of new life is just astounding.
It really is.
And the team was successful. They noted they were very happy with the level of care we were able to provide and the guidance we were able to obtain from colleagues.
And that successful outcome, despite the scarcity of resources, that really underscores our mission today. The success wasn't luck. It was due to a strict adherence to clinical standards, knowing how to leverage professional networks, and having that tactical discipline to maintain composure when everything felt out of control.
It's a masterclass in how expertise adapts when the textbook is literally blowing away in the wind.
Well said.
So let's return to that philosophy Dr. Spelsberg shared, the one that sums up this entire experience. We are born, we live, we die. Make the most of your short opportunity on this earth. If highly skilled professionals operating in their specialized life-saving field can be truly terrified by the unpredictable arrival of life, what does that teach us about how we need to prepare both logistically and mentally for the truly unpredictable events in our own lives?
That's a good question.
Are we relying too much on the assumption of resources and not enough on cultivating our own tactical stoicism and our own professional network? That's something for you to mull over until our next deep dive.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.